So welcome everybody to this first edition of our new series called Swiss Hybrid Imaging Webinars, organized by the PET group of the Swiss Society of Nuclear Medicine. My name is Klaus Strobel. I'm the moderator of today. This webinar is sponsored by Siemens Healthcare, and I want to thank especially Karin Karl from Siemens for her excellent help to organize this webinar. Before we start with the presentation, I want to give you some technical instructions. As attendees, you should have two windows on your screen, the webinar window and the control window on the right side. If you do not see the control window right away, then it might be hidden in the background and you have to minimize some other windows in order to see it. You have the opportunity during the presentation to type in questions in the comment field in the control window. I will collect the questions and we will answer as many as possible directly after the presentation. Please be aware that during the presentation, we will ask you some questions. A poll window will appear and you will be able to vote by selecting your answer and press submit. You will see it's quite easy. After the webinar, we kindly ask you to fill out a short survey to receive your feedback. We have chosen dementia imaging as a topic for today because amyloid PET is newly covered by the obligatory health insurance in Switzerland since 1st of April this year. Now it's my great pleasure to introduce our today's speaker. You see her already on the screen, Professor Valentina Garibotto from Geneva. Valentina is a well-known specialist and researcher in dementia PET imaging, and she will give us now a comprehensive overview about FDG and amyloid imaging in dementia. Please, Valentina, the screen is yours.
Thank you, Klaus. Thank you for the very nice introduction. Thanks to you, to the Swiss Society of Nuclear Medicine, and to Siemens for providing this platform and this opportunity. Let's see if we manage to go through the whole process without technical issues. We trained a lot for this, and thank you, Karen, for all your support. So I should start sharing my screen, and you should now be able to see my first slide. So the title of the presentation of today, we decided to focus on fluorodeoxyglucose and amyloid PET in dementia. We'll start with some disclosures at first. The first sentence basically means that Siemens is not taking responsibility for the content of the presentation, and it's only my responsibility together with the institutions I work in. And the following part concerns my personal disclosures. I received research support and speaker honoraria from some companies. Otherwise, I have no properties or consultant positions. So the outline of today's talk is I will briefly introduce what's molecular imaging, what's the role of molecular imaging biomarkers in dementia, and specifically in Alzheimer's disease, which is the most common condition associated with dementia. Then we will zoom in FDG PET and amyloid PET. I will briefly discuss what's the current clinical availability and reimbursement conditions for FDG and amyloid PET, with a specific attention on Switzerland, given that this is where I work and many of you work as well. And then we'll go with the conclusions. We'll draw some conclusions together. So first of all, dementia. Why to talk about it? Possibly you're all already aware that this is a very prevalent and common condition with a lot of burden on patients and families. And you see here a projection of the increases in number that are expected up to 2050 globally, worldwide. And this is mainly linked to the fact that we are aging populations, and that age is the major risk factor for this condition. When we talk about dementia, dementia is a clinical category, is a clinical definition, it's a syndrome, and it can be due to different diseases or pathologies. The way these pathologies are classified is, until now, the work of neuropathologists. So the types of diseases underlying dementia is really based on the type of inclusion of pathological deposits that can be observed at neuropathology, thus at autopsy, post-mortem. This is the gold standard classification. I don't know if you can see my pointer, but going from left to right, you see that when amyloid and tau deposits are present, a diagnosis of Alzheimer's disease can be done. When alpha-synuclein positive inclusions are found, this occurs in Lewy body dementias as well as in Parkinson's disease. And then people presenting with a syndrome-defined frontotemporal dementia might have different underlying pathologies. These can be inclusions of positive for tau, for TDP-43, or for FUS. In the current understanding of the disease, there are first these pathological deposits that have, in a way, a toxic effect on neurons that induce neuroinflammation and ultimately result in neurodegeneration. In this landscape, the place of the imaging tool we'll discuss today is amyloid PET, a marker of amyloid pathology, one of the two core pathologies in Alzheimer's disease, and FDG PET, a less specific and more widely, let's say, relevant marker of neurodegeneration. We know that glucose metabolism is, glucose is used by neurons and by astrocytes in synapses, in normally working synapses, and reduction, focal reduction, regional reductions of metabolism are associated with neurodegeneration. Another important information that comes with molecular imaging is that through molecular imaging, or in general biomarkers, we have discovered that neurodegenerative conditions are conditions that evolve over a very long period of time. You see here in the x-axis the clinical disease stages. Patients with neurodegenerative conditions have a very long preclinical phase in which no signs or symptoms can be identified. Then they often pass through a phase which is called mild cognitive impairment, defined MCI, in which there are already dysfunctions of, for example, verbal memory or language, but the person still preserves its autonomy. With loss of autonomy, one talks about dementia. And of course, this is the most disabling condition. So you see from this scheme that the aspects that can be evaluated clinically, the autonomy and the level of cognitive impairment, are things that can be measured only in the latest phase of the disease progression. And there is a long phase that is invisible to our clinical scales. In this phase, amyloid is one of the first detectable processes that can be identified and measured, and neurodegeneration is, as I said, occurring after the deposition of amyloid and tau. And these are the processes that our two imaging modalities can image. So imaging helps, in a way, provides a window to this very long preclinical or prodromal phase. I won't have time in today's discussion to go into the details for the acquisitions of these modality and into the details of the clinical indication that can be used for FDG and amyloid. That's why in this slide I refer to the procedural guidelines produced by the European Association of Nuclear Medicine or the SNMMI for FDG. They both date back 2009, and actually renewal process is ongoing. And there are also the joint SNMMI EANM practice guidelines of 2016 concerning amyloid PET. Another practical reference is the European Nuclear Medicine Guide. This is a guide which is freely available on the web, which has also a section on central nervous system, and that gives, in a very, a short, brief form, reference both on acquisition and interpretation criteria on brain metabolism and amyloid imaging. At this point, I would start interacting with you just to have an idea of the audience of what's your clinical practice, how familiar you are with the technique, and being that we will start with FDG, I would then like to ask you, are you using FDG PET in patients with dementia or neurodegenerative conditions? You see the question? and we will leave it up for a few seconds to see what is the distribution, yes or no. Yes, here it is. So the majority of you uses it. So that's very good. So being that you're all familiar with it, I don't need to spend time. The majority of you is familiar with it. I won't need to spend much time on describing this image. This is a typical FDG PET image showing that the glucose is taken up mainly in the cortical areas by the neurons in the gray matter and in some deep nuclei like caudate, putamen, thalamus. And then usually, a fairly homogeneous uptake, at least in the neocortex, is observed. In this, you can already see that these areas, these parietal, lateral, and mesial areas are lower than one would expect. Overall, the exercise with FDG PET for nuclear medicine specialists and radiologists is this. So you look for patterns, you try to recognize the patterns that are associated with specific conditions, because the neurodegeneration has a topographical distribution that is specific for the underlying condition. You see here, recapitulated in this figure, where the hypometabolism would occur in Alzheimer's disease, Lewy body dementia, frontotemporal dementia in the most common behavioral form, corticobasal degeneration, and posterior cortical atrophy. The images you show here are the results of an automated software processing. How does it work? The image in native space, as in this case, is normalized spatially to a reference space. This is what occurred here to the same subject. And then you end up having these maps of deviation from what's observed in a normal distribution. The normal distribution is usually obtained scanning a variable number of normal subjects. So in this case, for example, you see overlaid in green all areas that are 2.5 standard deviation below norms. This is very useful for this process of pattern recognition and is something that has been validated in multiple studies. Our Swiss Society of Nuclear Medicine recommendations specifically talk about the fact that this kind of support should be used for interpreting FDG PET and is based on literature. I want to mention here 2 papers using FDG specifically for the prognostic evaluation of subjects with mild cognitive impairment. This is one of the most common use of FDG PET imaging. Subjects with mild cognitive impairment won't ultimately not necessarily progress to neurodegenerative conditions and dementia. In some cases, mild cognitive impairment can only be the expression of, let's say, unsuccessful aging or forms of neurodegeneration that are very slowly progressing. While in other cases, it's the initial phase of Alzheimer's disease or frontotemporal dementia. FDG PET is very good at making this difference. And as it can be shown by this figure taken by this paper on the left, you see as rainbow map the results of interpreting the maps in native space. And you see that there is a lot of violet there, which corresponds to incorrect classification. So the image was considered, let's say, in favor of an underlying neurodegeneration when there was none at follow-up and vice versa. While, as you see, when SPM maps, so maps obtained with this standardized approach, SPM is one of the softwares that does that, were red, the interpretations were in this case totally correct, so all in the orange scale for this article, and with overall a high level of confidence. On the right, you have the graph obtained from a systematic review and meta-analysis of different papers using different markers, again, for the same purpose. So to evaluate, to identify those mild cognitive impairment subjects that are going to progress to dementia over the following 2 to 3 years. A diagnostic tool for this purpose, let's say the variables that I'm showing you here is the positive likelihood ratio of these diagnostic tests. The positive likelihood ratio, it's quite accepted in the literature that a value above 5 is a value you would look for a useful diagnostic test. As you see, FDG PET is the only test that is performing so well for this, let's say, short to midterm prediction of conversion or of decline to dementia. And in particular, if you see the block of FDG PET performances, the highest performance can be obtained, again, looking at SPM maps, so at these standardized maps. So this recommendation really comes from literature showing that this type of objective evaluation adds on to the visual assessment. For the indications, again, I won't go into the details, but I wanted to give you as reference the results of this work done by the European Association of Nuclear Medicine, the European Academy of Neurology, obtaining with a Delphi process consensus among experts for the main indication that should be recognized for FDG PET. Without going into details, they can be divided in 2 main categories. One is the use of FDG PET, again, to evaluate the prognosis, to evaluate the risk of progression to dementia in MCI subjects. And the other big category is the use of FDG PET to do a differential diagnosis. So to distinguish patients that have dementia or that have Parkinsonism to identify the underlying pathology. At this point, close the chapter of FDG PET, at least for a phase. We will go on with amyloid PET. And you see here the questions I would like to ask you. They will appear in a sequence. So if you're using yes or no amyloid PET, if you use it in clinical research or in routine, and then which tracer. So let's start. Are you using amyloid PET? No. Okay. So amyloid PET is a topic on which we'll have more, novel information coming to the public. Then for those who use it, do you use it in clinical research projects or in clinical routine? Clinical routine and clinical research, half and half. Okay, so it's good to see that it passed in the clinical routine for those who use it. And finally, only 2 options are visible, unfortunately, but at least to me. We thought including the 3 traces that are commercially authorized and in Europe and US, plus PIB as research tracer. Okay, then I see the 4 are visible, so that's perfectly fine. Majority of flow beta-bin, flutametamal, beta-peer, and PIB. So overall, the 3 commercial tracers are more or less equally represented, which makes sense. Okay. So, this slide mainly for those who do not use it, and those who are familiar with the different techniques will be able to recognize the tracer they use. Here I only see the three, let's say, commercially authorized traces, florbetaben, flutemetamol, and florbetapir, both in US and in Europe and in Switzerland. I didn't show PID images personally. I never worked, I mean, I only worked it remotely with it. But the principle of image visualization and interpretation is similar over the four traces. And as shown here, you have always on the right a negative image and on the left a positive image. I chose different color scaling following the recommendations that come from the different companies. They differ because different was the approach that was tested in the different studies, testing the specific traces, but again, the fundamental principles are similar. And so a positive image is a positive, is an image like the left one, in which you see signal in the cortex on the surface of the image. And the negative image is the image on the right, and an image in which you see signal binding only in the white matter, and this is linked to binding to the myelin. The validity of these visual approaches and in general of the method has been shown in a number of studies. I chose only two here, but multiple exist. There are, I mean, at least one per tracer. And these studies have been based on the idea of imaging subjects, either that were at the end of life and then following them up until autopsy in order to correlate, as it's done here in the image of the left side, the image pre-mortem and the results of immunohistochemistry on the autopsy data, or using a design like the one used in this right-hand figure, which was to image subjects that were undergoing a brain biopsy for other reasons. In this case, for example, for treating a normal pressure hydrocephalus. And as you see here, I mean, summarized in these two exemplary figures, scans that are positive correspond to a positive biopsy, and the other way around, with a very high accuracy, both sensitivity and specificity above 90% in general. So very good performance. Amyloid PET is really able to show in vivo what would be visible post-mortem as amyloid load. Of course, apart from these visual analysis, quantification or semi-quantification can be introduced. One approach is the SUVR approach, so measuring the average SUV in key cortical regions and the average SUV in a reference region. Different reference regions are used. Here I'm showing the pons. In other cases, it's the old cerebellum, for example. Or you can do the same approach that we've already rapidly discussed for FDG, so do a voxel by voxel analysis, normalize or standardize your image to a reference space, and then compare point by point or voxel by voxel the distribution you have in your subjects with the distribution you observe in normal cases. In this case, you would look for increases, focal increases, significant increases, as it's shown in this map by the red areas. And this, together with the SUVR and together with the visual interpretation in this case, was in favor of a positive scan. Being that we are dealing with different traces for amyloid, we have the issue of standardization across traces. This is a field in which there's been a very nice proposal, I would say the Centiloid proposal made by this group, Klunk and colleagues in 2015, and which is now used in multi-center trials and passing to the clinical practice. What is the general principle of it? If you talk about SUVR unit, you will have units that change a lot depending on the region of interest that you use. If you use the pons, which is a purely white matter region with a high binding, the ratio you will get will be relatively low, as you've seen in the value above, in the value shown in this figure. 0.6 is already a positive value, and you will have 0.9, 1 at maximum when it's positive. If you use the cerebellar gray, which is the cerebellar gray matter, an area that has no amyloid deposits, even in advanced cases, or very little, or only in advanced cases, you will end up with much higher values, making the ratio cortex versus cerebellar gray, as shown in this figure. In order to avoid, if you use different references, you won't speak the same language, and SUVR values will be poorly comparable. In order to solve this, the centiloid conversion uses 0 as reference for normal images, for the average of normal images, 100 as a reference for the average of pathological images, and then the rest is distributed in between. And an objective threshold for normal to pathological values can be defined. And of course, this conversion can be done not only for one tracer using different reference region, but also across different traces. In this case, for example, matching flow beta P on PIB, which is considered the common reference for all traces, you will end up having more or less line of identity as central tendency, and of course, some dispersion and some variability. So overall, you end up having values that are also, let's say, more intuitive, because if you have a scan which measures 80 or 90 centiloids, you will know that it's a pathological scan. And if it's 0, -5, you will know that it's normal. And you will also be able to define a normative value or a reference or a threshold that is common across traces. The added value of this approach is also to provide a measure for changes. Seeing, for example, changes induced by a medication. There are amyloid targeting medications that are still under evaluation and studied in clinical trials, but that are able to clear amyloid. Some have shown changes up to 50, 60 centiloids. And this gives immediately an image of how much an image passes from fully positive to much less positive or negative. Amyloid PET, we've seen, you're using it less. It's a more recent modality introduced in clinical practice, and it has also been accompanied by a number of questions. Studies have shown that it has analytical and clinical validity, that the measure we get are relevant and are matched with neuropathology, but is this ultimately useful for patients? In order to answer these questions, multiple large multicentric studies were launched. I will provide a couple details only on 2 initiatives. One is the IDEAS study. This is a real-world multicenter US study including subjects with mild cognitive impairment and dementia. They published last year in JAMA. This is the figure you have on the right, the results of the pre and post PET management change in over 11,000 participants. The study, at least for this aim, there are many others, but at least for this aim, was asking the referring physician what would have been the management of the patient at first without the PET amyloid result, and then to reassess it again with the results of the amyloid PET. And you see that the change in management you end up having with the information of amyloid PET is up to 60%, both in mild cognitive impairment and demented subjects. So it's not really different depending on the stage. It's more than half of the subjects for both, and concerns the prescription of drugs and also a minor proportion of counseling. This particularly for NCI subjects that ultimately want to plan for the future life based on the risk of developing a dementia or not. The AMYPET study is a multi-center European study conducted in multiple memory clinics. It has in particular a part that is a randomized control trial, so which will provide very strong data on the possibility to have amyloid PET as one of the first evaluation in the diagnostic workup, or, and this would be the early arm, or later, not earlier than 8 months after initial evaluation of the subjects. So we will compare these two arms. The preliminary analysis that have been done on the amyloid positivity rate observed in the first subjects and the first half of subjects included showed that indeed the population included is representative of what we expect. There was a 34% positivity in subjective cognitive decline, 58% in mild cognitive impairment, and 74% in dementia patients. I realize now that I didn't discuss specifically subjective cognitive decline, so I'll say just a couple words on this. This is, let's say, even earlier condition that mild cognitive impairment is considered an intermediate stage between the preclinical phase and mild cognitive impairment. It's, again, a very non-specific condition, so there are a lot of subjects that show this subjective impression of decline, but still have normal performances at test, that ultimately are only worried about their health, the brain health, and will not develop dementia. And in some cases, it's the earliest symptoms without cognitive impairment associated. So there is a lot of attention on this condition. The whole attention about preclinical condition is the fact that these are the conditions that will probably open possibility for treatment. Having given an overview on the two technologies, I wanted to provide you a practical example of how it looks like in combining these modalities in a patient. So we have a clinical vignette. The clinical information are really short. She is a 70-year-old female presenting with a primary progressive aphasia, logopenic, and MRI was course done and showing some global atrophy with some prevalence in the temporal areas. And this is the FDG PET that you can see. I'll let you a couple seconds to have a look at the images as they are, being that you're all familiar with, or majority of you is familiar with FDG. And then I'll also provide you the results of our standardized analysis. So these green areas are the areas that are below 2.5 standard deviation as compared with the norms. So there is significant hypometabolism in these areas. So in your opinion, this looks more like an Alzheimer's disease, a frontotemporal dementia. You think that it could still be in the spectrum of normal aging, or you do not know? We'll have a poll here. Okay, so majority of Alzheimer's disease, then a small proportion of frontotemporal dementia, and relevant proportion of I do not know. So let's see if your answer changes with some additional information. This is the amyloid PET result for the same patient. So you see here one slide to represent the visual distribution, which was indeed positive. You see the position in the periphery, in the cortex. Then you see the results of the comparison with a reference database, multiple areas with significant amyloid deposition, and an SUVR, in this case, using the whole cerebellum as reference, of 1.5. And normal values are usually situated below 1.1. So at this point, again, the same question. Is there anyone else wanting to change its interpretation? See? There's a higher percentage of Alzheimer's disease, and the percentage of I don't know or frontotemporal dementia lowered. Still, the percentage of frontotemporal dementia is not none, and it's a very good point. We'll see this in a minute. Before going further into this case, I wanted to open up another, let's say, perspective for getting more information out of our images. This would be the protocol that you would follow for amyloid PET scanning. You inject, then you wait for a time that is defined by the tracer, either 50 minutes or 90 minutes, and then you will get your amyloid distribution image. But one option, referred as dual time point amyloid PET, of course, one option would be to do a dynamic imaging over the whole time. Actually, this takes up 2 hours on a scanner, which might be not practical, but to combine different needs, one could also consider to image a variable number of minutes. 10 minutes could be enough, longer could be useful in some considerations. But you often protocol suggest an imaging up to 10 minutes, and then you will get an image which is an image of the perfusion. These brain traces have a very rapid early pass rapidly blood-brain barrier, and so the image that you get over the first minutes is a proxy of perfusion. We know that perfusion and metabolism are strongly coupled in the brain, both in physiological and pathological conditions. So we could imagine we get ultimately over these first 10 minutes images that resemble a lot the FDG PET images. In this way, with one injection, we get the two information. Of course, the patient has to pass 2 scans, but presented in this way, it allows you interleaving a second patient that does its first phase in between these two and a second phase after the first one is finished, and you can, let's say, improve the use of batches. Of course, you won't get the same level as only doing late static scans for all of them. And in this case, I can show you, for example, what is the distribution we observed when using the amyloid PET early phase. The 2 images are processed in the same way. So we have been normalized and smoothed as the software does, and then they've both been compared to the same reference database, which is an FDG reference database. So it's not completely correct for the image below, but still it provides you an image of maps of abnormalities that, as you see, are slightly less pronounced, but still matching very well with the metabolism abnormality that we observed. So this is a strategy to extract more information out of it, to be able to have, let's say, an idea of FDG distribution when you don't have one. Finally, a few words on the reimbursement policy. In 2017, we run at the European level a questionnaire that was described in the paper referred here, Zoni et al. In Lancet Neurology, that was covering different biomarkers for dementia. That's why you see listed here MRI, magnetic resonance imaging of the brain, remains the first step to exclude other causes of dementia and to have relevant information about the topography of atrophy that can be an indication in differential diagnosis. Then cerebrospinal fluid refers to the ability of doing via spinal tapping a dosage of amyloid and tau. So you can get the information of these pathological deposits also through cerebrospinal fluid, an indirect measure in a way. And then FDG PET and amyloid PET. And as you see, the situation in 2017 was the following. So while MRI, cerebrospinal fluid, and FDG PET were available with some differences in the majority of these European countries, amyloid PET was not, or very little. This is the situation in 2020, and do not guarantee that it's correct in all other European countries, because I'm mainly referring to the change that we had in Switzerland. Cerebrospinal fluid dosage of tau and amyloid was authorized, I'd say, a year ago or a year and a half ago, and amyloid PET, as Klaus has said at the beginning of the session, is authorized since the 1st of April. In which conditions? Then allow me a few words specific for the Swiss community. These are the reimbursement criteria for FDG PET. Unclear cases. After an inconclusive or impossible or contraindicated lumbar puncture, so what I'm referring to as CSF, cerebrospinal fluid measurement. After a multidisciplinary evaluation, the prescription has to come from a specialist in geriatrics, psychiatry, or neurology. There is an age limit until 80. There is a severity limit, not with a mini-mental, which is a global cognition scale that doesn't have to be lower than 10, which indicates a severe dementia. With a dementia duration no longer than 5 years, again, so not a long story, but something which is evolving over the last years, and without previous PET or SPECT. So in a way, the only test among the tests that exist in PET or SPECT domain. And for amyloid PET, you see the reimbursement criteria are identical. So the same policy has been adopted for the two. This corresponds partly to the current, let's say, recommendations of different societies. Different diagnostical algorithms exist. I'm mentioning here one that, again, emerged through Delphi process done among different society of imaging and clinicians in Italy, in this case. And usually diagnostic algorithm propose different step procedure in which you will have your first evaluation of the cognitive complaints and an MR or CT in case of contraindication. And then you can reach a diagnosis that allows you to say what if there is no cognitive impairment or if there is a condition that needs additional investigation. And then depending on the hypothesis you have on the clinical features and detailed neuropsychological evaluation, you will look for a specific test to confirm or infirm your hypothesis. And then you can reach the defined diagnosis, or you can still need additional information. And this won't be the case for all, but there will be some cases in which both FDG PET and amyloid PET might be required. As we've seen in the presentation, the indications and the specific questions to which the two test answers are different. And so a combination of the two might be useful. And the strategy of the dual point amyloid PET can partly solve the issue, but still early phase amyloid PET is in a way research procedure still, and full validation is still lacking. And then let me say a couple words on the latest development in the field, which is tau PET imaging. I go back to the first slide. These are the different types of pathology that occur in different neurodegenerative conditions. And as you see, Alzheimer's disease is defined by the presence of amyloid and tau. Well, over the last 5 years, there's been a great development of a lot of research on different traces targeting specifically tau. And very good results have been obtained. There are different traces targeting more specifically the tau forms that occur in Alzheimer's disease. Some seem more sensitive both for the tau forms of Alzheimer's disease and of other tauopathies occurring in frontotemporal dementia. And in this field, one tracer, which is the fluor tau CPR, has been FDA approved, news of May 2020, so it's very recent. So overall, it's a field that's progressing very fast. And with this information, I want to go back to the case we've discussed. So the majority of you think it's an Alzheimer's disease, and the positivity of amyloid PET has convinced you even more of it. And I do agree. And we were in line with this from the very first FDG PET. This is also consistent with the clinical presentation. I said it was a logopenic aphasia, and in logopenic aphasias are more often associated with an underlying Alzheimer's pathology. Still, one could say that this is very anterior in the temporal lobe, that there is limited parietal impairment. This is less common in Alzheimer's disease. And one could also say that at the age of 70, it's not impossible to have a frontotemporal dementia leading to the aphasia, and at the same time, an amyloidosis. I mean, co-pathology can exist. For this patient, I can also show you the fluor tau CPR PET distribution. This was done in a research study. And as you see here, these areas have a significant tau deposition, and they match very well with the areas of having a hypometabolism, with the additional information that tau deposition is larger, is more extended than the areas that are hypometabolic. So in this case, the tau image shows you that the neurodegeneration that we observe is tau related. And given that this tracer is specific and has a much higher binding in the presence of tau that is linked to Alzheimer's disease, I would say that this image is the final proof that in this case, this was a language variant of Alzheimer's disease. So I hope I convinced you over this presentation that FDG and amyloid PET are both clinically useful biomarker, with FDG being an excellent prognostic markers. So to predict, to see those MCI subjects that are going to develop dementia, and as well as a differential diagnostic tool, mainly in the pathologies that are non-Alzheimer, for which the information amyloid positive or negative is less relevant. Amyloid PET has the strength of being a molecular marker, so a marker that says that if a type of pathology is there or not. Both have an impact on patient management. I didn't show you results for FDG for the sake of time, but they are there. And amyloid PET is a strongly investigated field for this specific question. And diagnostic algorithms recognize their complementarity in selected cases. Then there are these novel specific PET tracers for tau, soon to enter the clinical arena. I'm very optimistic. I'm very convinced that this will be relevant data on this. We will present further at the upcoming Alzheimer's Association Imaging Conference, which will take place end of July. So if you want to know more about it, you're invited to follow. And with this, I would close. Thank you, grazie, for attending and for following. And I hope we'll have some questions to discuss it further.
Thank you so much, Valentina, for this excellent presentation. It was a pleasure to follow, and I think very helpful for our audience. There were some questions coming in, and I think we go through them. The first one is more general one, maybe some repetition of your talk. Which diagnosis can you do with FDG PET in dementia patients? Maybe you can just summarize again.
Sure. So the paper I referred to was really systematic in investigating all the specific indications. So when you have a patient with dementia with FDG, you will be able to see the topography of the different underlying pathology, and so see if it's typical for Alzheimer's disease, typical for its variant. So the language variant is the one we've seen in this case. The visual variant would be the one that was called in another slide posterior cortical atrophy. But then you can also see in the different forms of the family of frontotemporal lobar degeneration. This is a very complex family, different underlying pathologies and different clinical presentation that span from corticobasal degeneration, so someone which presents mainly with Parkinsonism and some specific cognitive disturbances, to a behavioral problem, to a language predominant problem. So in all these cases, you will have additional information with FDG PET. Also, in patients that are presenting not necessarily with a dementia, but with Parkinsonism, FDG PET is a very good tool to distinguish patients with Parkinson's disease, who usually have limited or no neocortical FDG changes, or patients with other forms of atypical Parkinsonisms, namely progressive supranuclear palsy, with a worse prognosis, and this is an important differential diagnosis and a different response to drugs.
Thank you. This question came from Muklejo Raman. And the next question, more specific, about SPM software. Do you think it is important to do a similar PET protocol to the one used for the normal database in the SPM software?
Definitely. So SPM ultimately is a software. You can have access to different reference databases. The consistency between the acquisition and the reconstruction used for the case test and the reference database is a very important aspect. Unfortunately, or fortunately, our discipline is a discipline that evolves rapidly. Every 4 or 5 years, we have new scanners performing better with higher resolution. And this is a problem when you want to keep up with a reference database, because of course, acquiring normal data is, a procedure with costs and with implications. A strategy that is sometimes adopted is to have very large reference database. So the larger the number, you will in a way gain in sensitivity and in information from the very strong statistics you have on normals, and then you will be able to compensate for some discrepancies in techniques, and then smoothing, so in a way normalizing additionally the information can correct from for more recent data that have a high resolution. Ultimately, resolution specifically for this indication for FDG is not a thing that changes a lot. It changes a lot for oncology, but for FDG PET images, having an improved resolution won't improve much your ability to detect the pattern.
Thank you. Another question from Begona Martinez about early phase amyloid PET. You showed SPM images. Which software do you use to get those images? Can you use FDG SPM software for early phase amyloid PET?
Personally, I do use it for clinical reference, for interpretation. I know that this is the experience also of the Leipzig group. I've seen publications from Henrik Bartel, Osama Sabri, using an FDG reference database to compare their early phase, I'd say, flow beta bed images. In this case was flutemetamol, I think, or flow beta peer, I don't recall. But then, I mean, ideally, again, one would like to have a reference database that is built out of early phases. We're in the process of doing it, but we didn't conclude the process yet.
Thank you. Another question from Bindang. How long should we set the scan time for each radiotracer, for FDG or for amyloid? How long do you scan?
The recommendations for FDG, I would say, are 15 minutes at least of scanning, 10 to 15 minutes. For amyloid PET, we usually scan 20 minutes for all tracers, but we've scanned for a shorter period of time, 15 with flow beta peer, and images were nice as well. So again, try to be consistent with your protocol. There are the, let's say, the professional information coming with the different traces provides you with windows. You can, even for the scanning, you can move it a bit from the 50 or 90 minutes within a range that has been tested. All traces, when they've been introduced, they've been scanned for dynamic, dynamic time. And so the companies can provide, I mean, and have published data that given a reservoir estimate of the differences with different timing.
Thank you. Another question is, can you differentiate types of TD, or frontotemporal dementia, using FDG? Can you differentiate?
Yes, so you can differentiate the different forms. The beauty of FDG PET is that it's strongly related to neurodegeneration, and neurodegeneration is strongly related to the clinical expression. So depending on the forms that are either language or behavior related, for example, you'll have more left temporal or frontal involvement. Then this is in a way also the problem with FDG PET. We could consider it a lack of specificity, because of course variants that mimic that same clinical picture will have neurodegeneration predominantly in those regions, and so an FDG image that won't be so different. So you could have an FDG image like the one I've shown you also in some FTD, pure FTD, primary progressive aphasia.
And Sonja Neubauer asks, if you have comorbidities with psychiatric diseases or depression or in early Alzheimer or brain concussion, how do they look in amyloid imaging?
In amyloid imaging, I don't expect much difference. And in FDG PET, they're normal. So there have been reports of reduced metabolism in anterior regions, in depression, for example, but this is usually mild and so not seen as severe as in degenerative conditions. Then chronic traumatic encephalopathy is a condition in itself and is a tau-related disease. So it's a tauopathy. I mean, multiple trauma to the brain induce tau accumulation. They have tested the different traces for tau. For tau CPA was also tested. There was a publication in the New England Journal of Medicine 1 or 2 years ago. But the results are, I mean, mild increase, difficult to see at the individual level.
Thank you. More and more questions coming in. We have some time left. From Irene Burger, our colleague from Switzerland. If Alzheimer's disease is suspected, would you go with early late amyloid if only one scan is reimbursed? This is
yes.
Swiss.
Yes, I mean, this is my personal recommendation. I'm partly, it's based on literature. Of course, early phase is still experimental, but in our experience, in the majority of cases, works very well. And amyloid will have the strength of providing a yes or no answer, which is very useful. Cases in which you want to balance this is if the probability a priori of an Alzheimer's disease is very strong on the basis of the clinical pictures, and the age is very advanced, then the risk of having an amyloidosis that is related to age and a clinical picture due to other is there. So for an older patient, possibly, and if the, let's say, if the main question is progression over a short time, FDG PET could be the first evaluation. But in general, if Alzheimer's, one of the hypotheses, the diagnostic hypothesis, I would go for amyloid, early late.
And our colleague Matthias Brühlmeier, he wants to focus you. In your opinion, which is the most important indication for amyloid PET in the clinical setting?
Early onset, relatively early onset, MCI subjects, and let's say up to 70, in which having an information of amyloid and further having an information of hypoperfusion will really change the management. And then, I mean, I hope that we will soon all see amyloid PET together with other amyloid tests for choosing patients for treatment. I mean, this is really something that is still lacking, unfortunately. There were promising news from one phase 3 trial last year. So let's see that if evidence builds enough to support the use of these drugs or other drugs come up. And this would be, I mean, a major changer, because of course, if we could use our imaging to select patients for treatment, that would be, I mean, wonderful. We know we do this for oncology, so we'd like to do this in dementia as well.
Another question, how do you separate dementia-induced changes of regional FDG metabolism from overlapping vascular brain disease-induced changes from Egbert Nietzsche?
Of course, this is tricky. All images, I didn't spend time into it, even if it's a hybrid, but I mean, I focused on the 2 traces because there are complexities on it. But of course, all images have to be interpreted in conjunction with MR. So MR will be the first test. In some cases, MR plus FDG will be done if you have a hybrid simultaneous PET-MR scanner. And then the topography of the FDG alterations and the vascular changes you will see in MR will help you discriminating the 2 aspects. But of course, this is something that affects FDG more than amyloid, for example.
Thank you. We just go on. What significance do you attribute to white matter uptake variances in amyloid PET, mainly with PET-PIP?
It seems, I mean, I wouldn't say it's more mainly with PET-PIP. It occurs for the other traces, even higher, I would say, with the fluorinated variants. It has been linked to myelin binding, and there are groups, I don't follow this literature closely, but I know there are groups testing it for example, demyelinating disorders. So multiple sclerosis shows reduction in demyelinated areas of this binding. We're exploring the binding in areas of white matter hyperintensities, and we found it lower. So it really links to the conditions of the white matter. Of course, it's in a way could be called off-target binding. It's not the one you're looking for. It's not amyloid, but at the same time doesn't really interfere with reading or scoring, because it's a different target area as compared to the one you're looking for, which is the cortex.
Thank you. Maybe the last question of today from Letizia de la Cueva. Any recommendation about differences between reconstruction parameters of the different amyloid tracers?
I mean, this should be really something that matches also your tomograph characteristics. I mean, you usually want to do a reconstruction that maximizes the performance of your tomograph, and then of course you have to get used in a way to it. To have a common reference, I usually use the ADNI reconstructions, acquisition and reconstructions protocols. The ADNI is the Neuroimaging Initiative, is NI, Alzheimer's and Dementia, possibly Neuroimaging Initiative. It's a very large American initiative that collected and made freely available for research thousands of scans, and these thousands of scans were acquired in a harmonized way across different vendors. So you will have protocols for acquisition and reconstruction that are for the different vendors and the different tomographs. That can be a good reference to start with.
Thank you. So I think we start to close this webinar. I would like to thank again our sponsor, Siemens Healthcare, and our today's speaker, Valentina Garibotto. I hope you enjoyed this session, and we see us again for the second edition of Swiss Hybrid Imaging webinars, expected in September, dedicated to PSMA PET. Please fill out the survey, which will appear in a second on your screen. Thank you very much for attending, and goodbye and take care. Bye-bye.
Thank you. Bye.